Hello and welcome to the EMS On Air podcast. The mission of this podcast is to keep healthcare providers safe, informed, and prepared. Today is March 5, 2021. I'm Jeff Lassers and I'll be your host. This episode was recorded on February 16, 2021. Even though we are located in Southeast Michigan and we mention our home state a lot, today's content applies to EMS on the national and even the global scale. This is a 4-part series focusing on EMS patient care reports, or PCRs. This series has been developed in collaboration with the Oakland County Medical Control Authority, or OCMCA, and various EMS providers as a way of providing information and guidance to EMS agencies and personnel. Although we reference the OCMCA and our local and state EMS protocols, this series is beneficial to all EMS agencies and providers. Like most EMS systems, the Oakland County Med Control focuses on quality assurance and/or quality improvement programs with a patient-centered approach. To facilitate this process, the OCMCA develops and disseminates required education to its EMS providers as one aspect of their annual EMS Quality Improvement Program, or EQIP. Since 2015, EQIP has provided a uniform, standardized, systematic, and responsible quality improvement program through education and OCMCA support. EQIP can be broken down into 3 primary components that all OCMCA EMS agencies are responsible. These include required data reporting, required education, and measurement of protocol knowledge through assessments. In 2021, all OCMCA EMS agencies are responsible for assuring that all of their EMS providers complete this 4-part series or cover the same learning objectives with their personnel. All of the details regarding the 2021 EQIP requirements can be found at ocmca.org/EQIP. EQIP. That's ocmca.org/EQIP. Again, even though this series was developed specifically for EMS providers in Oakland County, Michigan, it certainly applies to EMS on the national and even the global scale. It is impossible to cover every detail, aspect, and nuance of an EMS patient care report. However, we hope that EMS providers and agencies use this podcast series as a way to start a conversation and/or train on producing quality PCRs that consistently show an understanding of current protocol knowledge as well as patient-centered decision-making in the field. Throughout this series, you'll hear from a core group with a vast amount of experience and knowledge. Everyone that appears in this podcast series has significant experience with EMS education, QA/QI programs, as well as EMS agency and system administration. Joining us in today's discussion, we have Bonnie Kincaid, who is the OCMCA Executive Director. We are also lucky enough to have Emily Bergquist here with us, who is the current State of Michigan MCA Coordinator, as well as a longtime paramedic and EMS Instructor Coordinator. We are also joined by Emily Baker, who is currently the EMS Coordinator at Ascension Providence Hospital in Southfield, Michigan, as well as the CQI Supervisor for Alliance Mobile Health, which is a private EMS agency in Oakland County, Michigan. And finally, last but not least, we're joined by my friend John Thoit, a longtime firefighter paramedic and EMS Instructor Coordinator who is the new OCMCA Quality Improvement Coordinator, as well as a shift captain and the EMS Coordinator for the Ferndale Fire Department, located in Oakland County, Michigan. You can find our guests' contact information in the episode description. In this episode, we'll discuss the data elements and requirements of EMS patient care reports. Primarily, our goal is to increase EMS's appreciation and awareness of all the required and/or applicable EMS PCR elements so that they thoughtfully select values, as well as how to implement best practices into their work. To accomplish the goal, our guests will help us list and describe the terminology related to PCR data entry. Then, we'll list and describe the minimum data elements that must be completed in the PCR of an EMS transport of a patient. From there, we'll discuss the additional elements required in the PCR of an EMS transport of a patient with a time-sensitive emergency. We will round out the discussion by listing and describing the minimum data elements that must be completed in the PCR of an EMS patient care refusal, an EMS patient dead on scene, and an EMS termination of resuscitation in the field. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Also, check out our website, emsonair.com, for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air. And please, whatever podcast platform you use, subscribe to the podcast and leave us a rating and a review because it really helps us to grow this podcast. I really can't ask you guys this enough. Please leave us a rating and a review and help us get noticed on a much larger scale. Remember, the mission of the EMS On Air podcast is to keep healthcare providers safe, informed, and prepared. So, increasing our ratings and our reviews gets us noticed by more listeners and more sponsors that will lead to increasing our reach, resources, experts, and abilities. Bottom line, ratings and reviews are currency in 2021. It is vital to our growth, and your contribution will give us what we need to serve those that serve our communities. The only cost to you is a few minutes giving us a rating and a review on whatever podcast platform you use. We're available on every podcast platform that you can think of, so it's super quick and easy. Thank you, and enjoy the podcast. So as the introduction said, it's very important that an EMS provider and an agency and the patient assure that there's a patient care record there and everybody's got a job to do. Emily Baker, can you please list and describe the applicable terminology related to electronic patient care record data entry?
All right, so before we start using these terms over and over again, it's very important that everybody understand what we're talking about when we say them. They're used nonstop when we're discussing state data or national data for EMS systems. So if we start from the provider side, when you as an EMT or paramedic or MFR are looking at the software you're doing your report, you see all of these blank spaces. And those are the data fields. That's where we're going to put in answers. Those are the sort of buckets that the information is dumped into. Every single one of those fields has what we call conditions related to it, and those are the rules for that particular field. So for example, for your pain scale, when it's rated on a scale of 1 to 10, the conditions do not allow you to enter a value of 15. Even if that's what your patient said, it is not properly applicable to the scale being used. There are conditions or rules for every field in your EPCR. The value is what you actually use to fill in that field. So the 5 that I enter for the pain scale, or Emily for first name, that is the value. That is our data in. And then the elements are the data out that the state actually receives and what they are working with. So in some cases, that may be different in appearance than what you enter. You may enter a medication, but in the background, it's defined by a code. And that is what the state receives as an element that allows the computer magic to happen that transfers all of that data.
So what I got out of that is when I open up a PCR, I have a bunch of blank data fields. And basically everything that needs to be filled in is a field. It's a data field that wants to be satisfied with information. And then the conditions, they really set the rules for every one of those fields, what can or cannot go in there, because sometimes I want an address that's actually, free text. And sometimes I just want you to from a drop down. And then the value is the actual thing set in there, right? The actual drop down, the actual information. And then the element is the measuring tool.
So the elements are like their scientific name. That's the best description I have for an element. For example, when you put in a primary impression, there are usually things like chest pain, for example, and those are linked to an ICD-10 code. The element is an ICD-10 code, and it's many numbers long, and it has a super long description, but providers don't want to search through every ICD-10 code in the entire universe, and so the backside, that PCR system, the software, makes that link for you. So you see the value and that super scientific elements on the backside.
So my job as an EMS provider is to fill in all the appropriate data fields, and then the conditions are just how I interact with it, the values, the information I put in, and the elements is the extracted data pulled out by the national system in order to know what's going on.
Right, and it's the agency's job to verify that those elements are matching the values. Those conditions can actually trigger, those rules can do a lot of different things. So like, for example, those conditions, if I say I tell the system, if you pick primary impression of stroke, you must fill out a stroke scale. They can create all these different rules based on those specific fields and what you put in as a condition. It can kind of lead people to document in a better way. So if you are an agency person and you're not utilizing that, I highly encourage you to use those rules because it will help your providers be better documenters.
So there's all these data fields that need to be filled in. So Emily Berquist, help me out by listing and describing the minimum EPCR data elements that must be completed in an EPCR for an EMS transport of a patient. That's anybody, not just time sensitive, but all runs.
There's a whole section in the beginning of the PCR. All of the times, the dispatch times, the en route time, the arrive on scene time, the information about the scene itself, like what kind of a place are you going to, what is the incident location. It's not necessarily the same as the patient's address, for example. So there's a whole section kind of incident information, how you got there, did you use your lights and siren, did you not use your lights and siren. All of that is kind of in that initial first set. We can go back to our difficulty breathing. You get dispatched for a syncopal episode, you get there, it's a patient with difficulty breathing, you figure out that they're having a STEMI. So those things don't really track. It just doesn't track across very clearly. So that's part of the information that needs to be in there as well. So demographics, I'm not going to talk about every single specific thing that's inside demographics. And I don't mean like address, for example, because yes, I know some people are homeless and you can't fill that in. I get that. But making sure that you're attaching that record to the human that it belongs to. So I'm not writing a report about Emily Baker and it's getting put in Emily Berquist's medical record. You know, we have to make sure that we're being specific enough that we can make sure that things that need to be linked are linked. So demographics, and this goes for every single patient. Chief complaint, what is the patient complaining of? Provider primary impression, which is not necessarily the same thing as chief complaint, right? So a patient might be complaining of difficulty breathing, but they're having a STEMI. So the patient's complaining of difficulty breathing, that's what you'd put in there. But your primary impression is related to the STEMI, not necessarily the same thing. So they are two different things. Your assessment, and that is variable depending on what type of patient, like physical assessment, breath sounds, blood glucose, stroke scale, all of that kind of buckets into the assessment. Any and all vital signs that you have assessed, they go in there. And for a transported patient, you should have 2 sets of vital signs. I'm not really interested in debating about times. People are always like, oh, well, we only transported for 1.5 miles. I don't care. Take one on scene, take one in your vehicle. You can get 2 sets. Don't want to hear your sad story. Emily.
I think that it's important for people to realize that unless you have at least 2 values, you cannot call your patient stable because stable means unchanging. You can say that your patient's vital signs were within expected defined limits or within normal limits, but a stable patient is an unchanging patient. And if you have not reassessed things, you cannot call your patient stable.
And patients also get moved. You moved your patient. I guarantee you moved them because they don't teleport. So every time you move a human or do something to a human, you need to check and see if something changed. You should be getting 2 sets of vital signs.
Let me just step in here because I'm somebody who does that. And I have these very short transport times on some of these locations that are located very close to a hospital and my station. So in those situations, when people tell me, well, I was only with the patient this long. Well, you got to the patient in their home, which we have these residential institutions, and then we take a blood pressure. And then we put them on a cot, we do a bunch of stuff, and then let's say it's just across the street. Well, it's a long driveway. Hit the blood pressure button before you drop them off. You were with them a minimum of 15 minutes. I don't understand what the problem is.
Yeah, so, and you can also take it when you're walking down the hallway to go to the patient's room. It can be taken wherever.
Fantastic. So I get vital signs in there. What else do I need?
At least 2 sets of vital signs. Any and all interventions. So that includes procedures, intubation, splinting, bandaging, fill in the blank, and then medications, any medication that you gave, and the things that changed, which we kind of mentioned, anything that changed or did not change with your patient. And then your narrative, which is the story. And the story is really important. It's super important. I've seen many hospital physicians pick up a PCR and go immediately to the narrative. because it's difficult to read and get a good idea of the patient without the story. And then the other pieces I'm going to call the EMS information. So who was there? Who's the crew? Who did what? Who intervened and did different things? Who wrote the report? And then the signature of the person who wrote the report. And I think that's the general giant categories of what you need.
Perfect. Okay, so then what about for patients that I not only transport, but they have a time-sensitive emergency, sepsis, STEMI, stroke, priority 1 trauma? What's the difference there? What other things do I need to assure happen or are included in that PCR?
There are specific elements for many time-sensitive emergencies that are really, really important. So, for example, if we use like a trauma patient, mechanism of injury is very, very important. How fast was the car going? Where was the person in the car? Did they have a seatbelt on? The number of extra elements when you're talking about specific types of trauma patients, falls and car accidents and things, the number more of things that we're going to expect you to put in there are all of the things relative to that person's injury and when it happened. And then what were they like when you first found them? And did anything change? That becomes even more important when you have a time-sensitive emergency. So that's kind of trauma. So stroke, we talk about the stroke scale. It's the MCA-approved stroke scale. Wherever it is that you happen to be, the stroke scale has to be documented. The last known well time is important. Even if it was yesterday, it's still an important time to have. And there are all sorts of different variations that EMS is not aware of and changes all of the time as far as like what neurological interventions are available. So that last known well time is so important. If you can find it out, find it out. If there's somebody else there to ask the questions, because the hospital's not going to have access to the same things that you have access to. And then for STEMIs, it would be obviously 12 leads, serial 12 leads. If the 12 lead is changing, also onset time. Obviously, that seems to be a trend across time-sensitive emergencies is onset time. And then for sepsis, what the underlying situation was and how much fluid the patient has gotten are kind of the big things that people really look for.
The only big things that I would add when you're looking at your stroke or CVA patients are also when their symptoms were discovered and if there have been any changes since then. And then for all of our time-sensitive emergencies, we really, in the hospital environment, are concerned with having contact information for a next of kin. If there is a possibility of this patient's condition deteriorating very rapidly, we need to be able to call someone. I would also like to stress anything that happened prior to your arrival. I feel that sometimes people leave those things out because they did not do it. However, if the patient took 3 nitro prior to your arrival and then their EKG changed 5 minutes after your arrival, that's relevant.
Well, I do know in my platform that I use, there is the option for treatments to be denoted given prior to arrival. You know, you can list a care provider, maybe you're at an urgent care, it was a nurse or a physician that you're transporting out of. And there's plenty of opportunities in all these platforms to denote that. So it is included not only in a narrative, but also listed in other locations as well, like the treatment section, the flow chart.
Aspirin's a good one, right? That one gets given prior to arrival a lot because a lot of dispatchers are telling people to take aspirin in their pre-arrival instructions. So you can actually denote, at where it's 1:15 right now, I got here. They took it 5 minutes ago. At 1:10, check the box prior to arrival. Patient self-administered aspirin. So one, it's in their record that they took the aspirin, but you have it. It's there for documentation. So you can absolutely do that.
Another big one's like oxygen out of a nursing home or even an EpiPen from the field, stuff like that. There's plenty of opportunity to put it there.
If the IV was established prior to your arrival by a different provider, that is also very relevant. If the IV was established at the urgent care or at the extended care facility, there's a lot of different things that can be done before you get there. And we need to be aware, one, that they were done, and two, when and where.
Absolutely. This quick commercial break is brought to you by our educational partners, American CME. AmericanCME.com is an online continuing education learning platform designed for EMS providers by EMS providers. Their mission is simple: create and host high-quality video-based EMS CE content with the aim of improving the quality of EMS care while drastically reducing or eliminating the cost associated with EMS training. American CME courses focus on the most current topics and science related to the EMS industry and are available in a format that makes them convenient to access and complete. Over the last year, the EMS On Air podcast has teamed up with American CME to host many of our episodes on AmericanCME.com. This means that EMS providers can earn EMS continuing education credits by completing an entire podcast episode, a brief post-course quiz, and a survey. To do this, visit AmericanCME.com, click on the courses link, then click on free courses. Scroll through the course list and look for the courses with the EMS On Air podcast logo. Currently, there are 22 different EMS On Air podcast episodes hosted by AmericanCME.com, including the episode you're listening to right now, that are approved for continuing education credits for EMS providers in Michigan. But don't worry, we're working on getting our episodes approved in all 50 states and CAPCI accredited. And we'll be releasing another batch of episodes sometime in May 2021. Get on over to AmericanCME.com and get you some credits. Think about it: kicking back and engaged in an EMS On Air podcast episode and earning CEs. Come on, does it get any better than that for EMS continuing ed? Did I mention that you can access all of American CME's content for free? Yeah, free. And now back to the show. Now, to kind of shift a little bit here, some patients don't get transported. Oftentimes they can refuse. Sometimes they don't feel that an ambulance or EMS is necessary for their injury, or sometimes they just don't want us to be there. So can you, Emily Berquist, help us understand what should be listed and described as a minimum for an EMS patient care report and all data elements where a patient has refused care and or transport?
So I'm going to preface this with, these are cooperative patients. If it's an uncooperative patient, you document that the patient's uncooperative, and that's okay. I can preface that so nobody's listening later and saying, but what if the patient's not cooperative?
Yeah, to set the stage here, let's say for everything, the advice you're going to give right now, what should be included in these refusals, A&O times 4, right, with no obvious life threats. We're all in agreement that these patients are appropriately being refused. But the idea here is, what specifically should be in that patient care record?
I think the key point to this is remembering that when you're doing a refusal, you're trying to document that it is appropriate for the refusal to be happening. Or if you don't feel that it's appropriate, that it should be happening, you're documenting that as well. So 1, the patient is A&O times 4. You had best be documenting the patient's capability to make their own medical decisions. It has to be in there. You can put that in the assessment where you're documenting the neurological assessment, and then you're putting it back in the narrative to really reiterate that the patient is clear and aware and capable of understanding the consequences of refusing a treatment and or transport. You're going to document who is there to witness you saying it, like family member, friend, even if it's just your partner, who all is there, and what you actually said to the patient about it. Today's a great day. In Michigan, we had a big snowstorm. There's like probably 11 million people sliding around in ditches and things like that. And you get there and the patient's like, I don't really want to be treated, and they're actually fine and everybody's good. If you're not worried about the patient dying, don't put in there that the patient could die. Put in your actual accurate assessment of what you told the patient. Then you're going to get your signature and the patient's signature. Those are really, really important. Your patient has to sign that you said, yes, I will take you to the hospital. And they said, no, I do not want to go to the hospital. And then obviously we already talked about vital signs before. Any appropriate vital signs. The patient is actually okay. Their blood sugar is normal. They're not hypoxic, etc. That goes into the whole, the patient is capable of making their own decisions. When I wrote refusals, my refusals were 90% of the time longer and more complicated than my transports.
That's important for everybody to understand, is that you need to document the heck out of that. And if you called medical control, what happened there? Document that as well.
Yeah, who did you talk to? Like, which doctor did you talk to? Yeah.
Let's use this as a quick opportunity to remind people what are those refusal situations that I should contact medical control.
Well, the answer is anytime you're not sure and or if you've conducted an intervention and the patient's refusing. You don't get to just like go out into the universe and willy-nilly pass out treatments and then be like, see ya, have a nice day. You know, if a patient who doesn't normally take albuterol needed an albuterol treatment, you should probably talk to somebody else about that because something happened that was different than normal. Or if there is a patient who is questionable, you know, have I had a patient who was having a STEMI refuse? Yes, I have. And did I just let them sign that literally their life away and walk away? No, I did not. I have a very good coming to Jesus speech that I can give, but I also can contact a physician and have them give a coming to Jesus speech. So those are kind of the two that I really focus on when you talk about when you should talk to medical control is one, if you've done an intervention and you had to stop it to leave them there. And two, even if your spidey sense doesn't feel right or the patient is obviously sick, those are the times that I would be talking to medical control.
So you kind of started to go into what I wanted to bring up. I think that it's important to highlight that when you call medical control for a refusal, we are still kind of bound by laws and kidnapping is still a real charge.
You're right. You can't force a patient to go, nor can the doctor. But I can tell you that in a 20-year full-time on the ambulance running calls in a really busy system, I had one patient in the entire time that ever said no to the doctor. When you actually try and express, a patient is usually maybe begrudgingly willing, but willing to go. And sometimes it's about finding out, this is like off documentation way, but sometimes it's about finding out why they didn't want to go. Like I had a patient one time who it was soup day at his facility and he did not want to leave before he got to have his favorite kind of soup. And so we went to the kitchen and got the soup and took it with us to the hospital. Completely ridiculous, but he needed to go to the hospital and he was fighting with me. And I was like, well, this seems simple enough. I'll just get you a cup of soup. But you're right, Emily, you can't force somebody to go who doesn't want to go. But you do have a responsibility to try to get them to go. And that's the balance, I think.
And I think the duty to act is that you tried and then you called somebody under those situations and then you documented that it happened. And then in most situations, as long as the recorders are working correctly, they should be being recorded and you're calling the correct line at the hospital. And as a reminder for those agencies that are joining our eComs study, you can use the eBridge app to do face-to-face, almost like a FaceTime situation with these docs. And sometimes that might even be better depending on the information you're trying to convey either to the hospital or to the patient. Now, here's a different type of patient that may also benefit from something like the eBridge app when I'm talking to medical control. But before I call medical control, let's talk about ePCR data elements that must be completed in a PCR for an EMS patient that is dead on scene.
For clarity's sake, you mean dead on scene, not a termination of resuscitation?
Yes.
Okay. So if it's a dead on scene patient, that means that you get there and you're like, woo, that person's dead. And or, oh, they have a valid DNR. They're a hospice patient, et cetera, et cetera. They're dead. I'm not intervening in that. So the key to the documentation in that is why is it that they're just dead? And that happens, right? Like we are not miracle workers. We can't raise people from the dead. The key documentation here is what criteria did they meet? Is it super simple? Were they decapitated? We can't fix that. Is it something we couldn't fix? Is it they're frozen to the ground somewhere and they've been there for 5 days? Whatever those things are that make it so the patient is dead on scene and not eligible for resuscitation, that's what you need to document in your dead on scene. On top of demographics, background, narrative, etc., what specifically made it so the patient met those criteria?
Okay. So basically look at your dead on scene protocol. Make sure that they meet that criteria. Document the criteria that they meet.
4, whatever it is.
Now, how does that compare and contrast to a person that you're terminating efforts for on scene?
I think that termination of resuscitation is the single most difficult thing, one, to do, and two, to document. Termination of resuscitation, you have started trying to bring someone back, and you are not successful. Once you have called medical control and verified that it is okay to terminate resuscitation, then you would document your call, and that would involve a really, really long narrative that told the whole story, every medication that you gave and what did or did not change. The attachments of your EKG are really, really important in this case. What rhythms they were or were not in throughout the resuscitation effort, and every rhythm that you saw. So if you saw them in VTAC and then they went into VFib and then they went into asystole, and that was, you have to document. You saw every single one of those. And then once you get all of that in there, you have to have your physician's name that you talk to and the time of death that that physician gave you when you were talking to them. So you're working the patient, continuing working the patient, a person calls and gets a termination order from online medical control, then you have to document all of the pieces that went into that particular thing.
Now, all the pieces that go into our run are listed like in a flow chart or treatment section. There's a vital sign, there's an assessment section. I use those three sections when I'm looking at any type of run, and I compare them to the incident times. And I'm really cognizant of the chronological nature of what you saw, when you saw it, and what you did about it, and then what happened to the patient. Many times that I'm reading these things, I don't think the times are always accurate. And I don't think that's always the fault of the EMS provider. Sometimes settings are there that they aren't always as articulate with the times as they should be. Can you touch on the importance of making sure that all of your times for treatments, assessments, and what you found and what you did are accurate?
Times are important because, one, people change, right? Especially when we were just talking about these termination of resuscitation patients. If you saw they were in VFib and then you gave epinephrine and then you gave amiodarone, but you inserted somewhere in there that they were also in asystole and those times don't line up, it makes it look like you didn't treat them appropriately, because amiodarone is not for asystole, amiodarone is for VFib. So you have to make sure that your times and your interventions are lining up appropriately with your vital signs. And PCR software, some of them are more tricky than others. I don't have a FEB brand or anything, but pay attention to how your PCR software puts times in things, because some of them default to the time is now versus they default to patient contact time. It just kind of depends on what system you're using. Don't let a machine give you a time that's not real. And that also ties back to your monitor. If you come in the morning and your monitor's time is off, you should be raising your hand and saying, hey, agency boss person, my time is wrong. And that's a problem, right? If I get an order from a physician for termination of resuscitation and my time on my monitor is an hour off, that looks really bad, because all of those times are going to come over to your record, and then you're going to change it, which makes it look like you're altering a record. So just make sure that you're paying attention to the times, and the times are the things that you actually did and when you did them.
Yeah, I totally agree. And a lot of times in my platform, when I, let's say after the call's done and, oh, you know what? I didn't put the IV in. And when I hit the IV started button, it's the time that I hit that button. So I got to make sure I go back and I got to look at what time I did that, because I don't always have enough hands and time to hit that button exactly when my partner is starting that IV. So sometimes I kind of do have to guess that it was at that time, but I'm not just leaving it at a general time. I'm legitimately, if it happened before I left the scene, my time's going to reflect that.
Yeah, after right? I put them on the monitor and before I left the scene, or, you can get a pretty good get a great idea,
because sometimes I've read reports where it's like, hold on, this person started the IV, but they didn't go with you to the hospital. No, he did it before we left. What else is wrong with your report and times that did or didn't happen?
Right. Or six things happened at the exact same time. Right. Like, how did that one person do 6 things all at the exact same time? They were doing CPR, they put in an IV, and they intubated all at the same time? How can that be?
Those can definitely lead to confusion, but the big thing is when they get to people like Emily Baker at the hospital, they're literally looking at this document to see what happened in what chronological order, to see, where are we at with this? Emily Baker.
Well, I'm usually most impressed when you see that only one provider out of the 6 that were on scene did absolutely everything on that call. I'm very proud of that particular provider and concerned about their colleagues. But that's correct. Really, the timing that is as documented and the order of interventions is incredibly important as everything is being evaluated.
Anecdotally, the worst beating a provider that I know of ever took at a deposition was in regards to times. So everything took you 1 minute. Everything happened all in this time frame. And that was the biggest concern when I prepped a couple of my EMS providers for a deposition. After the deposition, they came back and said, yeah, that was awful. And that was the worst part.
Yeah, if you do go into a situation where there's going to be any type of litigation and it's identified that your documentation looks off, they might leverage that situation. What else is off? That is all for the show today, everyone. Thank you for listening. Thank you to all of our guests for coming on the show and spreading your knowledge. If you want to get a hold of any of today's guests, you can find their contact information in the episode description. Also, I'd like to take a quick moment to recognize the other EMS providers that were directly involved in the development of the content presented in this episode. Thank you to Allison Bellitti, Luke Bowen, Justin Allen, Yehuda Kranzer, Chris Watts, Matt Prang, and Dan Miller for your time and participation in the development of today's content. Your time is truly appreciated. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Also, check out our website, emsonair.com, for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air. And please, whatever podcast platform you use, subscribe to the podcast and leave us a rating and a review because it really helps us to grow this podcast. Thank you for listening to the EMS On Air podcast. Stay safe and have a great day.